My name is Ed Septimus. I'm in the Department of Population Medicine at Harvard Medical School. This is part two of the webinars, which I've entitled AMR, The Inconvenient Truth, Antimicrobial Resistance. And I've started off with a summary of what I consider inconvenient truths. CAP, or community-acquired pneumonia, really the guidelines that are out there both in the UK as well as in the US, really target empiric therapy against the most likely bacterial pathogens. However, we know from the studies I reviewed previously that even with more extensive microbiological testing, including PCRs for viruses, that the etiology for CAP may only be identified in about 50% of cases. And so better diagnostics are urgently needed to rapidly and accurately identify which patients are more likely to not only benefit from antibacterial effect, but occasionally antivirals, and if there are resistance genes that might need to be taken into account when in choosing empiric therapy. So improvements in cultural techniques, and now we've seen an explosion of new rapid diagnostic platforms have significantly improved pathogen detections. And as I mentioned, by adding viruses, we've really increased the detection rate. And so more recent studies, as I've reviewed earlier, show that viral causes, either by themselves or with co-bacterial infections, may be present in 15 to 30% of cases. And that's fairly new for adults, or very well known for children. The other thing is that antimicrobial use has gone up significantly during the initial COVID pandemic. And most studies showed that less than 5% of patients admitted with COVID pneumonia actually had a co-infection with a bacterial organism. And this really has driven up the amount of inappropriate and broad spectrum antibiotic use, which has actually driven significant increase in both healthcare associated infections with multi-drug resistant organisms, as well as the increase of multi-drug resistant organisms across the board. The other thing which is important, we've talked about CAP, but the diagnosis of healthcare associated pneumonias can also be very challenging, and that's where we see a lot of multi-drug resistance. So the diagnostic challenges around lower respiratory tract infections or pneumonia is, number one, we know that timely, effective antibiotics is critical to improving the outcomes of patients with pneumonia. That we know that bacterial pathogens may be multi-drug resistant, such as MRSA or CREs, which is carbapenem-resistant Klebsiella pneumoniae. And we also know that lower respiratory infections can be primarily bacterial or viral, but occasionally we see fungal pathogens with COVID. And the question is, how can we fit these new diagnostic platforms, these multiplex platforms, into our diagnostic and therapeutic armamentarium to better select empiric therapy and improve outcomes? Now, if we look at community-acquired pneumonia versus healthcare-associated pneumonias, we've gone over pretty well what community-associated pneumonias look like. The big three are Staph aureus, Streptococcus pneumoniae, and H. flu. Depending upon where you live, you may see certain atypical organisms. In adult, it's primarily going to be Legionella. However, as I've shown you before, viral has begun to become very important now that we have the diagnostic capabilities. Now, for healthcare-associated infections, many of these have had prior antibiotics, and you can see Staph aureus is still very important, but now we begin to see the emergence of gram-negative organisms such as Pseudomonas, Acinetobacter, and other Enterobacterialis, and many of them may be multi-drug resistant. So what has been the impact of COVID? I've mentioned this before, but let's kind of look at this. When we saw COVID, we didn't really understand all the implications around patients presenting with COVID pneumonia. We thought they may have a severe bacterial pneumonia that at the same time as COVID, and as I've already alluded to, the bacterial infection co-infecting with COVID is extremely low. Some of the predictors may be they're older, they came from long-term care, they've had underlying kidney disease, they're in the ICU where they have higher white counts. Procalcitonin has been used to kind of help in that regard, that if you have a patient coming in that looks like COVID pneumonia, bilateral interstitial infiltrates, low white count but high CRPs, and an undetectable or very low procalcitonin, that's a very high negative predictive value that that patient does not have a co-bacterial infection. And many people have used that as a helpful guide. On the other hand, if it's positive, that is greater than the 0.5, again, only about a quarter of them may only have viral, but you can see the incidence of bacterial infection goes up. But again, most patients do not have co-infections with bacteria. Now, what's happened through COVID is what's shown on this slide. There's been an alarming increase in resistant organisms in terms of carbapenem-resistant Acinetobacters. We've seen much more Candida auris, that multi-drug-resistant Candida species, carbapenem-resistant Enterobacteriales, ESBLs, VREs, multi-drug-resistant Pseudomonas, which has multiple different mechanisms of resistance, and MRSA have all alarmingly gone up during COVID. In addition, as I've alluded to, healthcare-associated infections have unfortunately gone backwards. We've had a significant impact over the last decade of reducing device-related infections and MRSA, but as you can see on this particular slide, and I put in the box, that VAE, which is ventilator-associated events, many of them being ventilator-associated pneumonias, have gone up almost 50%, especially these chronic ventilator COVID patients. You can see why that risk factors have gone up so much. So what are some of the challenges moving forward? As I mentioned on the front end, the patients who come in with COVID pneumonia, or what looks like a viral pneumonia, the concept is, yeah, what's the harm of a few doses? Yeah, it really can't hurt. There's really no downside to starting patients on antibiotics. But as this particular very nice study shows, that there's a downside of giving inadequate antibiotics, or there's also a downside in using overly broad antibiotics when a more narrow spectrum standard therapy is adequate. And there's multiple reasons for that, but again, predominantly because unnecessary broad spectrum antibiotics increase Clostridioides difficile infections. It selects out for more multi-drug resistant organisms. It disrupts the gut microbiome, causing dysregulation and immune system changes. And broad spectrum, of course, increases the risk of a resistant hospital-acquired infection. So we try to get the sweet spot. We don't want to miss the pathogen, but if we use overly broad antibiotics driven by the fear of a multi-drug resistant organism that's not necessary, we may also decrease the outcome of that particular patient. So we really want to find that sweet spot and figure out how these new diagnostic tools can improve the diagnostic accuracy and get us from empiric therapy to targeted therapy in a much faster manner. And that's sort of shown on this particular slide. As I mentioned, that fear of missing a multi-drug resistant organism really drives unnecessary care. And in doing so, we select out for more resistant organisms. And if the patient gets a healthcare-associated infection, they're more likely to have a multi-drug resistant organism. And we know that stewardship, and both antimicrobial stewardship and diagnostic stewardship, have to be hand in glove if we're going to achieve actionable information that can decrease the overuse of antibiotics. It exerts that pressure on gut flora, which again causes overgrowth of multi-drug resistant organisms, and those organisms that were colonized, if we do get infected, we usually get infected with those that are colonized with multi-drug resistance. So we need to sort of combine what's shown on this slide, the role of diagnostic and antimicrobial stewardship. We want to, of course, have the clinical evaluation. We want to do the right test on the right patient at the right time, using the new diagnostic methodology if we can. But in the end, we have to combine antimicrobial stewardship, which now, how do you interpret those new tests? What's the right targeted antibiotic? And can we do it in a timely manner so that we reduce the selective aspects of broad spectrum antibiotics? But I can't overemphasize the use of clinical evaluation. So the key takeaways from this section is that appropriate indication and specimen collection, I should mention, is critical. You want to try to get the right specimen before you start antibiotics. And It's both for typical microbiology as well as the new diagnostics. No one rapid platform may meet everybody's needs. There's no question that using these new rapid diagnostics by decreasing diagnostic uncertainty will hopefully provide us with more targeted therapy. But again, to be effective, as I mentioned, it's got to be combined with stewardship programs and make it actionable and making the decisions timely and discontinuing antibiotics when they're not necessary, de-escalating when we can, and occasionally escalating when we find a resistance marker that means we should be escalating care. And we also always should monitor for unintended consequences, and testing every time still has to be correlated with the patient you're seeing at the bedside. With that, I'm going to end this section. I think this is a good way to think about thinking versus doing. I think we need to have a combination of both. I hope you'll stay tuned for part 3, where I talk about how we leverage innovation in improving the diagnostic accuracy for patients with pneumonia.